it is now my absolute pleasure to welcome our first presenter, Dr. Peter Millay. Associate Professor Peter Millay practices as a consultant haematologist in clinical and laboratory haematology at the Princess Alexandra Hospital and is Associate Professor with the University of Queensland Medical School. He holds appointments with the Medical Scientific Advisory Group of Myeloma Australia, the Australian Amyloidosis Network, and the National Blood Cancer Task Force. He is a past chairman of ALLG and current chair of the Australian Amyloidosis Network. He heads the Myeloma Service as well as the Queensland Amyloidosis Centre. We are so grateful he's with us today to present on advances in myeloma treatment in the current Australian climate. Thank you, Peter.
Thanks very much, Kath. So it's now my pleasure to be able to talk a little bit about the role of treatments, particularly new treatments, CAR-T and bispecifics in the current Australian climate. And I'd like particularly just thank one of my colleagues down in Adelaide, Dr. Cindy Lee, who's lent me several of her slides. Particularly, you'll notice the ones that are prettier. So this is what I'm going to talk about. Just have a little overview of where we are at the moment in terms of current therapies, where we've come from. Then talk a little bit about the role of the immune system in cancer, because understanding of this has led to an explosion of a new therapeutic approach. And that is the use of what's called CAR-T cells and bispecific antibodies, as well as antibody drug conjugates in the management of multiple myeloma. And I'll briefly mention some of the other new therapies that are around the corner as well. So what's our goal in treating myeloma? What are we trying to achieve? It's a highly treatable type of cancer. It probably remains incurable. And a few years ago, this slide said it remains incurable, but I'm not so sure anymore. I think there are a proportion of patients that are experiencing incredibly long remissions in excess of 2 decades. And with the introduction of some of these therapies that interact with the immune system, I think the therapeutic outcomes with myeloma may indeed be changing. And so I'm not so sure anymore that it's an incurable cancer. But in terms of practically, what are we trying to do when a patient presents? We're trying to achieve remission, that is to kill as much of the myeloma as possible. We need to manage complications along the way, and that includes complications of the myeloma itself, as well as complications of the treatment. And also important and not to be forgotten is to control the bone disease. And I'll just mention one slide on this because it's a very important part of treatment of myeloma. That is management of bone disease, which still the majority of patients with myeloma have to some degree. In fact, pain remains a very common presenting symptom of myeloma because of the destruction that happens with the myeloma cancer in bones. So getting pain relief is very important, particularly early on, but equally important is over time to wean down that pain relief. Radiotherapy remains a very important treatment modality, particularly if you've got a myeloma bone lesion pressing on something important like the spinal cord. It's very important for some patients who present with their myeloma only in one spot and nowhere else. That's an uncommon situation called a plasmacytoma, or it can be very useful for persistent bony lesions. It's also important for all myeloma patients to be treated with some type of drug to reduce future fractures, reduce the likelihood for need for an orthopedic surgeon to have to come and strengthen a bone. These are drugs called bisphosphonates, of which the 2 most common in use are pamidronate and zoledronate. And not only do they help control myeloma disease, but in fact, patients live longer if they're on a bisphosphonate. So it's an important part of treatment. A more recent treatment available is a different class of agents, but doing a similar job, of which there is one called denosumab. It's approved in bone disease for other cancers, but not yet reimbursed in Australia. So what have we got to treat myeloma? Here's the list of not every myeloma therapy, but the ones we've got available. And if you can see, I've got a little mark next to some of them as to whether they're available on the PBS, that is, they're available to all Australians at no cost, or whether they're only available at the moment through a medicines access program, that is, the pharma sometimes give away the drugs either for free or at a price, but they're available, or if they're only really available at the moment on trial. And so we've got these different classes of agents. We've got the immunomodulatory drugs, which are all derived originally from thalidomide. And there's lenalidomide and pomalidomide on the PBS. And there's a couple of others that are probably not too far away, iberdomide, and the drug with a lot of numbers has got a name now, mezigdomide. These are both very potent drugs of this family. And they've got the advantage of being oral therapies, offering convenience. We've got the proteasome inhibitors, of which the first one was bortezomib. There's a version which is a little like oral bortezomib called ixazomib. And then the second generation proteasome inhibitor, carfilzomib, all very active drugs in myeloma. We've got what we can call traditional chemotherapy agents, which are drugs like cyclophosphamide and melphalan. We use melphalan in particular in high doses with autologous stem cell transplantation. Then there's the monoclonal antibodies, of which we have ones directed against CD38, a molecule that's on the surface of all myeloma cells. And those ones are daratumumab, which is available on the PBS, and isatuximab, which is only available in certain trials. Elotuzumab targets something different on the surface of myeloma cells and is available on the PBS, whereas belantamab, which has a drug toxin attached to an antibody, is only available on trial or on compassionate program. Then we've got some other drugs. Selinexor is the only one of these available on the PBS, both in combination with Velcade and by itself. We have T-cell engagers, of which there is one, teclistamab, that's available in a medicines access program, but it is expensive. Otherwise, there are numerous trials in Australia of various T-cell engagers. We have CAR T cells available only on trial at present, and a new class of drugs, BCL2 inhibitors. This is an oral therapy, highly effective in myeloma, but yet to be worked out how to safely deliver the drug. So they're the therapeutic choices that we've got at the moment. And here's the way in which they're used. Up the top in blue, I've got now. This is kind of how we use them. And in the below in blue, the future, how they might be used. So at the moment, there's initial treatment to control the myeloma. And this is, for most patients in Australia, a combination of lenalidomide and dexamethasone, or those two drugs with Velcade as well, the so-called VRD regimen. And for patients who are young, and young in myeloma terms is less than 75, so maybe not what the population thinks is young, but if you're young enough and no significant health problems, a transplant, an autologous stem cell transplant to consolidate that initial response. And then whether you have a transplant or not, some form of maintenance, which is typically lenalidomide at lower dose and continuing until there's problems with side effects or until the disease progresses. And then if the myeloma comes back, we've got a variety of agents as listed on the previous slide, but there are various regimens based on daratumumab, carfilzomib, pomalidomide, selinexor, elotuzumab, in a variety of different combinations. And at this point, treatment becomes much more individualized, depending on things like prior responses, side effects from prior therapy, ability to travel to a center to receive an injection as opposed to an oral therapy. Treatments are very much different between different patients in that setting. In the future, though, what would we hope to get available in the shorter rather than longer term? Well, certainly the ability to get daratumumab in the initial treatment of myeloma in combination with Revlimid and dexamethasone. This is a highly active therapy. It's had a proven role for patients who are not transplant candidates. And it's again before our funders to see if it might become available. In other patients, the ability to have carfilzomib up front may also be beneficial. It may be in future we won't be using lenalidomide as maintenance, but maybe one of the newer agents in that family, like iberdomide or mezigdomide. And in relapse, at the moment, we're hoping to get CAR T cells approved at later lines of therapy to give us another very powerful option, which we'll hear about later on in the seminar. We hope to get some of these newer bispecific or trispecific T cell engagers that I'll explain a little bit more about. Maybe venetoclax will find its place because it's very active in particular types of myeloma. So that's kind of where the field's heading as an overview. So just to talk a little bit about one of those therapies, which have been around for a long time now, since the mid-90s, and that's autologous stem cell transplantation. Autologous means your own stem cells are being used as opposed to someone else's, which is called allogeneic. The stem cells are in fact special cells in the bone marrow which give rise to all of the cells in the blood. So your stem cells give rise to all your white cells, all your red cells, all your platelets. And transplantation refers simply to putting back those cells into the body so that they can grow up again. And you can see in the diagram there that the process involves moving those stem cells out of the body, out of the bone marrow where they normally live, to circulate in the blood where they can be collected from patients. They're stored down, they're measured to make sure they are going to work well. And then after some initial high-dose chemotherapy, which is what is the active agent in treating the myeloma, in killing the myeloma cells, the stem cells are given back because otherwise after that dose of chemotherapy, the blood cells would not recover on their own. So the stem cell transplant is a way of supporting the ability to deliver a very high dose of chemotherapy. And then after a couple of weeks, those stem cells grow back up and one recovers from the transplant. It is, however, an arduous and difficult therapy, but it works, which is why we still utilize it. Just to give you some of the idea of how things have come, in the left-hand graph, which in the yellow you can see trials in myeloma, 1985 to 1998, predominantly younger patients with myeloma. Over that 13-year period of trials, there was no improvement in outcome for patients with myeloma until the first trial published over 20 years ago now in 1996 from the French, which demonstrates that patients who received an autologous stem cell transplant were living longer than patients who didn't. And that's the graph with the curve on the top being those who received the transplant. If we then look at what's happened more recently, and this is just some data about younger patients, that is those that have a transplant, there's really been a lot of improvement compared to 20 years ago. The median survival for patients that have standard risk myeloma, so this is patients who don't have problems in their genetics that predict a higher risk of relapse. The median survival in these registry and recent trials is over 12 years, and that's a marked advance on where we were 20 years ago when it was less than 5 years. In the top graph, top table, you can see some data from the Canadian registry, similar to our own registry, where they're looking at outcomes for myeloma. And the reason I've put that in is that outcomes in trials are always better than in the real world because trials pick fit patients who don't have marked health problems, whereas registries like the Canadian one are a better reflection of what's happening in the real community. And their results are maybe not quite as good as the trials, but certainly very impressive. And if you can see in the bottom right-hand corner, this is the most recent data from a trial that we participated in Australia as well as internationally, which was a trial looking at the standard treatment we have now, VRD induction, followed by transplant, followed by rituximab maintenance. Patients have amazing outcomes. This is overall survival out to about 4 years, and still at that point, more than 90% of patients are alive. So there's definite progress being made. I'm just going to talk briefly about the cause of myeloma to lead into the next topic of therapies. We don't know for sure what causes myeloma. It probably is genuinely bad luck, but it's not caused by infections. As far as we know at the moment, it's not preventable. Nearly all cases are preceded by a precancerous phase called MGUS, and that's been shown in studies of US veterans who have blood tests taken often decades before they develop myeloma, and you can go back and see this precancerous phase. But we need a better understanding of disease biology from research to work out what's causing myeloma. There may be a role of what we call the bone marrow environment. The other cells in the bone marrow that surround the myeloma cells, how do they impact the ability of a normal plasma cell to become a cancerous one? And there's certainly a link between the immune system and cancer across all types of different cancers. So if we look at the immune system, we know it's important in all sorts of cancers, and it's certainly important in myeloma. But obviously, if myeloma is progressing, it's learned to evade the immune system. So would it be possible to retrain the immune system to fight myeloma and overcome the sneaky things that the myeloma cancer cells have done to make themselves resistant to the immune system? Your immune system's got a number of different cells in it. It's got B lymphocytes. These are the cells that mature to go on to produce antibody. There are T cells, which do much of the direct killing of different cells, including cancer cells, and they've got NK or natural killer cells. So there's all these different cells in the immune system that are there to do the work. There are myeloma cells, which can have a coding which could be recognized potentially by drugs if it's different from what's on normal cells. And then we can use that immune system to try and direct one of these cells, the B cells, the T cells, the NK cells, other immune cells, to try and target something on the myeloma cells so that there's less killing of other cells in the body, which is one of the disadvantages of chemotherapy. There have been vaccines developed to try and target your immune system to attack the cancer cell, just like we use vaccines to target them to treat infections. There's CAR T cells, which we'll hear a little bit more about. Monoclonal antibodies, such as daratumumab, are a type of immune therapy. We've got bispecific antibodies and T cell engagers, which force various immune cells to attack the myeloma cells. We've got antibody drug conjugates, where an antibody selectively delivers some sort of toxin direct to the myeloma cell and not to the rest of the body. And then we've got checkpoint inhibitors, which are widely used in other types of cancer, but haven't yet proven to be useful in myeloma. The thing with trying to target the immune system to a cancer cell, though, is you need a target on the cancer cell. And in the case of myeloma cells, we have got this target called BCMA, or B cell maturation antigen. It's expressed on all plasma cells, including myeloma cells, but little is expressed on any other tissues in the body, and therefore it's a good target. Its overexpression is associated with progression of myeloma, and therefore is very useful to direct the immune cells to bind onto this BCMA to facilitate the killing of the myeloma cells. It's not the only target at the moment. There's a number of others. There's targets called GPR, C5d, FCH5R, SLAMF7. The actual kappa and lambda light chains can be targets as well. So there's multiple targets that have been developed or are being discovered, but used to target myeloma therapy. So in terms of BCMA targeted immunotherapies, there are a number that are useful. There's antibody drug conjugates, and this is belantamab. There's CAR T cells, of which there's 2 products that have been developed and commercialized at the moment, and they attack the BCMA target on the surface of myeloma cells. And there's bispecific antibodies, again, 2 of which have been commercialized, teclistamab and elranatamab, both of which bring your killer T cells into close proximity with the myeloma cells. So I'm going to talk a little bit about each of these. So firstly, what is CAR T cells? So the CAR T stands for chimeric antigen receptor T cell therapy. So the chimeric antigen, bringing together bits of different proteins to force the T cell to attack directly the myeloma cell. So it's an immune therapy that changes some of the body's T cells to improve their ability to fight cancer. Their production is actually a complicated process. First, the T cells have to be collected from the blood, a little bit like stem cells are collected, but in this case, we're trying to collect the lymphocytes in particular. Then those lymphocytes have to be manufactured in a laboratory. That is, the target has to be introduced into them so that they're focused on attacking myeloma cells. You have to have some sort of therapy to control the myeloma while this manufacturing process is being undertaken. You then have to have some sort of chemotherapy to make sure that the body's immune system doesn't immediately reject the T cells, the CAR T cells that are being made, and then they have to be reinfused back into the body. How do they work? Well, they're a type of white cell, the T cell, that normally is responsible for attacking cancer cells or infectious cells. And their function is to identify abnormal changes in a cell and then to destroy it. In terms of CAR T cells, they've been specifically re-engineered in the laboratory to change a property on their surface. So they've added a gene so that their surface receptor is recognizing something on the myeloma cells so it can then attack them. Now, there'll be a bit more detail about CAR T cells in some talks to come. But I'm just going to mention there's been a number of trials conducted and reported looking at CAR T cells, and these are just some of them. But I just want to briefly mention one trial that's being completed recently, the CARTITUDE-4 study. So this trial was only recently published at the end of last year, where it was comparison of the CAR T cell against one of our most active combination, which is pomalidomide, daratumumab, and dexamethasone. There was another choice, but mostly patients received this therapy. Patients either received the CAR T, called cilta-cel, or that therapy that had relapsed myeloma. Their myeloma had to have progressed while taking lenalidomide, which is very relevant to our context because most patients receive lenalidomide maintenance as part of their first therapy. And then they had to have had 1 to 3 prior lines of therapy before going onto this trial. So if you had more advanced 4 or 5 lines of treatment, you couldn't get onto this trial. And this trial was important because it was our gold standard. That is a randomized controlled trial where half of patients get one therapy and half get the other. So this is where we really see how good a treatment is. And these were the results. On the left panel, these are the response rates. So how many patients get a very deep response? This is a complete response. So using our common blood and urine tests, this is where we can't detect the myeloma anymore. And you can see markedly improved in the CAR T group, which is the orange bar graph compared to the right, the blue one. And this translated to improved control of the myeloma. So the curve on the bottom right, called progression-free survival, is a curve of how well the myeloma is controlled. And you can see 18 months down the track, markedly more patients have not had their myeloma relapse in the CAR T group in orange compared to in the blue group. So this was definite proof of the effectiveness of CAR T compared to the best available therapy, even better than what we can get in Australia on the PBS. So proof that the therapy is definitely efficacious. But you may also have noted that patients continue to relapse, even those who are getting CAR T. So why do they not always work? It could be that the myeloma is too aggressive and some patients progress in that time even before they can get to having the CAR Ts. In some patients, the CAR T cells just seem to be less effective. Or it may be that they don't persist long enough in the body to exert ongoing effect. It could be that the myeloma cells learn to not express the target that is being attacked by the CAR T cells and they evade the immune system. Or it could be that there are other mechanisms that the cancer cells develop to evade killing by the CAR T cells. And all these mechanisms are under investigation to try and define ways to stop the myeloma cells being able to evade the CAR T cells. In the future, they'll be looking at trying to get the T cells earlier, because the immune system and the T cells work better before someone's had many lines of chemotherapy. There might be the opportunity to develop CAR T cells from other donors, so-called allogeneic CAR Ts or allogeneic NK cell therapy, so-called off-the-shelf treatments, which can be available straight away. Or maybe there's the use of other targets besides BCMA. There's also attempts to optimize the manufacturing process so it can be sped up to get CAR T cells that are more efficacious or have less side effects. There are, though, alternatives to CAR T cells. We're mostly familiar with the plain antibodies such as daratumumab, which binds to the myeloma cell, and then one of the immune cells latches onto that antibody. We've got drug conjugates, which I'll come to, but I want to focus more on bispecific antibodies. These are antibodies that have been manufactured, so one half of the antibody binds to the myeloma cell, and the other half binds to your T cell, thus forcing your cancer-killing T cell right next to the myeloma cell and forcing direct killing of the myeloma cells. So these bispecific antibodies are what we call an off-the-shelf product. They're like a drug. They can be available at any time to start treatment and don't rely on the time needed to manufacture CAR T cells. And there can be so-called bispecific antibodies or bispecific T cell engagers, but they both have the same principle that can be seen in the picture on the right. They bring your T cell into close proximity to your myeloma cell to force myeloma cell killing. There's a number of these types of drugs in early phase clinical trial and in some in advanced phase clinical trial. And two of them have achieved registration in the US, but not yet in Australia. They've got reasonable safety profiles. They do have cytokine release syndrome, although that's manageable in most patients and a little easier to manage than in CAR T cells. But they do have problems with increased rates of infection down the track, and this is an area that particularly needs to be improved. Most are intravenous or subcutaneous injections weekly and then either fortnightly or monthly, so they are a therapy that gets easier as the treatment progresses. Most of them at the moment, because they're used in later lines of therapy, are ongoing until disease progression. But the responses are very impressive, 62 to 83%, compared to 30% or less with most traditional therapies. Here's a slide with a lot of detail in it, but it does show there's a number of trials that have reported out with different bispecific antibodies in myeloma. There's actually probably more than 30 trials underway in various stages of conduct. These are the trials that have been reported in the relapsed setting using drugs against BCMA, teclistamab, or against one of the other targets, talquetamab. There's elranatamab, which has also been used against BCMA. You can see all of them have been used in different populations, typically patients that have received a lot of other drugs. And their response rate has been so promising that just like CAR T cells that are being moved to assess earlier lines of therapy, indeed being used upfront as initial therapy, to see if outcomes with the current treatments can be improved by bringing more efficacious therapy upfront. So in summary, with these bispecific antibodies, there are several of them that exist, an advanced stage of clinical trial, and also in the stage of becoming available around the world. They target different targets on the myeloma cell. All of them force your T cell to directly attack the myeloma cell. The maximum response and duration of response is yet to be fully determined. We need some full follow-up on the trials. It's possible that future will be combining them with other agents to maximize their tumor killing, and more work needs to be done to improve their safety profile, particularly in regard to reducing infectious complications. So we now have CAR T cells and bispecific antibodies, which both use the immune system to directly kill the myeloma cell. And they've both got pros and cons should they become available. There's no doubt that the bispecifics are available straight away for patients. They're a product that can just be sitting on the shelf, whereas CAR Ts do have to undergo manufacture in specialized centers. There probably will be a limited number of centers where CAR Ts can be given, at least initially. Hospitalization is required, at least in Australia, in most centers at the moment for CAR T cells, whereas there is less hospitalization required for the bispecific antibodies. A great advantage of CAR T cells is a single one-off administration with no ongoing therapy, whereas bispecifics are ongoing treatments required, even though the schedule may become less intensive. There are toxicities of both approaches, which you'll hear about in a subsequent talk, and they're certainly both expensive. We don't know how they'll be priced exactly in Australia yet, but rest assured they won't be cheap. I've mentioned a couple of final points on other treatments. Belantamab is a drug where the BCMA antigen is targeted on myeloma cells, but a toxin called MMAF is attached. This is a treatment that looks effective, but it's got a unique toxicity in the eye, and its best way of combining with other drugs and positioning in myeloma has yet to be fully worked out yet. A recent trial looked at belantamab, didn't meet its endpoint of being more effective than pomalidomide, and so more development needs to occur. The next generation of the thalidomide family, the so-called CELMoDs, is in development. Iberdomide and mezigdomide, these are very powerful agents, oral agents, so they're attractive and will probably be used mostly in combination or as maintenance therapy. I won't go through the data on this trial comparing the different efficacies, but clearly the CAR T cells and the bispecific antibodies are very effective compared to some of these other agents. In conclusion, the future of myeloma is bright. There's significant progress made from decades of research to discovering new therapies and translating them into trials and availability for patients. There are multiply active immunotherapies at the moment, which appear very promising. And the current issue is to, one, get them available, but to work out how to optimize the timing, sequencing, and management of side effects. Just to give you a pointer of how far we've come, 40 years ago to 30 years ago, all we had was melphalan and prednisone. Complete remissions, 2% at best, 1 year survival, 20 to 30 of patients always died in the first year. We couldn't make an impact on that. Transplant improved things further. If we come down to the recent trial of VRD and daratumumab, 80% complete response rates. But if we look at CAR T cells, we're getting similar complete response rates to our upfront therapy, even though this is in patients who have received 6 prior treatments. They really are extremely effective therapy in terms of getting myeloma under control. This is a study that was published a few years ago looking at relative survival. So this is the survival of someone with myeloma compared to the aged and gender-matched population. So you can see over the last few decades, we've come an awful long way from a relative survival of around 25% to over 50% with the development of therapies. We've still got a way to go to get the relative survival to 100%. That is, to either make myeloma truly a chronic disease or to cure it. But progress is being made. That's all I've got to say. I'm happy to take questions. It's an exciting and optimistic time for myeloma. Thank you.
Thanks so much, Dr. Malay. We do have a couple of questions that have come through the line. We have one from Babsy who asks, how far away are we from DARA as first line, and will we get quad therapy in Australia?
So we don't know the answer to that. I mean, daratumumab in combination with Revlimid and dexamethasone has been submitted twice to our regulatory authority, the PBAC. It's been accepted as a safe and efficacious combination by the TGA, but the issue is primarily around price. So I guess it's being submitted again, and look, we really hope that it'll become available. It really is a very effective but very tolerable therapy, and this is very important for older patients with myeloma. In terms of quadruplets, I guess the company hasn't yet looked at making submissions to the government for upfront addition of daratumumab. It has been shown to be effective in younger patients treated with VRD and transplant. That data has just been published. So we'll wait and see. I'm sure that'll be in the company's plans, but I don't think that will be this year.
Thank you. A question's come through from Bill who asked, do we know what causes myeloma?
No, we don't. I mentioned bad luck, and that probably is the case. There's a small number of situations where we know that myeloma is caused by. One of those is high levels of radiation. So people in Hiroshima, Nagasaki, Chernobyl, they develop myeloma at greater rates. In fact, one of the people who worked on the atomic bomb in the US developed myeloma 20 or 30 years later. So there's no doubt that high levels of radiation are important. But apart from that, there's a lot of uncertainty as to the exact causation of myeloma.
Thank you. A question about, is transplant still the best therapy available in Australia?
So for younger patients who can tolerate the procedure, it still is. And as every new therapy has come along, there's been attempts to replace transplantation. When lenalidomide came along, a trial was done to compare, a regimen with lenalidomide versus transplant or not, and outcomes were not improved. It remained superior in the transplant arm. Velcade came along, the similar trial was done. Velcade and Revlimid combined came along and a similar trial was done. There is a trial being conducted in Australia and internationally at the moment, which will directly compare CAR T cells with autologous stem cell transplant. And we'll see if that shows that a therapy can beat transplantation in terms of control of myeloma. But to date, it still seems to be a highly effective therapy, more effective than not having a transplant. That only applies, though, if you're fit enough to have a transplant, and that's a complicated assessment.
That leads nicely into probably the next question as well, which is, if you haven't had a transplant, would you still be eligible for CAR T?
So at the moment, there's nothing in the wording about CAR T cells about having had to have had a transplant or not. It's all about lines of therapy, of which transplant is one. I think we have to try and get it available in Australia first. And again, it's up before our bodies that assess the availability of funded therapies in Australia. And we keep our fingers crossed that there'll be a positive outcome for that submission. But it comes down to the price of these therapies rather than their effectiveness, which seems to have been accepted. It's really, can Australia afford that therapy?
Absolutely. And I think, as you alluded to, then working out the sequencing, isn't it, where we best fit in these lines of therapy. Questions still coming through. Thank you, everybody. We've got one here. My hematologist has advised a BiTE trial as I have relapsed for the third time. What things should I consider?
So I think when you get to your third relapse, there's no doubt that the response rates to bispecifics look superior to any other option that we have. the things I'd consider is it a trial where there's a choice between two therapies, the BiTE therapy and something else? And what is that something else? Is that suitable? It's highly likely on most BiTE studies in Australia at the moment that the control arm is better than what we can get on the PBS at the moment. So you should look at that carefully. I think, though, if you look at every therapy that we have available in Australia at the moment for myeloma, it's because a patient before you has participated in a trial and proven that that therapy is effective. And on the basis of those trial results, it then becomes available for everyone. So I would say, consider the data in the trial carefully. Consider what your doctor's saying carefully. Speak with your family and your GP. But I think generally speaking, the care delivered on a trial is high quality, and you will be helping availability of treatments for patients in the future.
Great, thank you. And what looks like our final one, there's been a recent report about secondary T-cell malignancies after CAR-T. Can you offer any further information?
Yeah, so there was what they call a black box warning in the US that's been put out on all CAR-T products. And this relates to the occurrence of a greater than expected frequency of T-cell lymphomas. So T-cell lymphomas are a cancer of the T cells, and part of the manufacture of CAR-Ts is that those T cells are manipulated. So at the moment, they've had more cases than expected, and some of them, they suspect that the CAR-T manufacturing process might have led to the development of those lymphomas, but the data is a little bit too early to be sure about that. So it's been listed as a warning. All centers that administer CAR-Ts have to track long-term for the development of these types of cancers that may be related to the CAR-T process. At the moment, they seem extremely uncommon. So if you like, the benefit of the CAR-T in preventing progression of the myeloma, in fact, getting it into remission, far exceeds what seems to be a very uncommon event at the moment. But I think all of the side effects of CAR-Ts and this report of possible T-cell lymphomas is but one, need to be investigated, and there's a lot of research being done to try and reduce risk of these things. So a lot more to follow in this story about T-cell lymphomas, early days, and at least for the moment, a very uncommon side effect.
Right. Okay. Thank you so much, Dr. Malay, for your time and your expertise. A reminder, if you do have questions, you can send them via our nurses inbox, and we can reach out to Dr. Malay after or assist in answering those questions. Thank you so much again.